Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. This is of a patient who attended with an ear infection in both ears, and they are actually a YouTube fan and subscriber, and they travelled from Birmingham today actually to my clinic in Leicester, which is about 40 miles each way, I suspect. I actually studied in Birmingham. I went to Aston University to obtain my degree in audiology. So I'm partly familiar with Birmingham, and the patient has been suffering from this chronic infection in both ears for the last year, believe it or not, and they've been referred by their GP to see an ENT doctor, but the waiting list at the moment is so incredibly long, in part due to COVID and the backlog, that the patient has yet to receive their appointment, and it's been about a year already. They have received a letter asking them to arrange a telephone remote consultation, but unless someone's going to be able to look in the patient's ear and actually physically treat it, it's just going to go around in circles. They've been somewhere local as well, but because he's got an infection, they said they can't really do much in terms of removing it, so patient decided to visit myself. Now, they have got a history of glue ear as well. I'll come on to that a bit later. So what we initially did, I used the suction probe, and we're just peeling away all this dead keratin skin and all this oteris, this discharge, this pus, and the skin is now infected. The ear canals, I suspect the patient's ears are narrow in any case, but it was also quite inflamed, so especially near the entrance, and it really restricted my movement inside the ear because it was so narrow. Nonetheless, we did persevere, and we did a pretty good job, I feel. Patient was really satisfied. Even during the procedure, they felt really relieved, and so not only do they enjoy watching the videos for that same reason, but actually experiencing it themselves. They really enjoyed having the procedure done, and I can imagine, I can empathise and relate to that really, because there was so much discharge and gunk in the ear. The ear must have felt really heavy and hot and sticky, and by giving it a good clean, it really, really will help. Now, I did explain to the patient that by performing microsuction and removing the dead skin, the arteria, it will no doubt obviously help stop the infection, but it won't fully. Therefore, until they do see ENT, I've recommended some acetic acid spray they can get over the counter. What the acidity does, your ear should be naturally acidic, because I think the average pH, or the range should I say, is between 5.4 and 7.1. So there's a natural acidity of our ear, and the acidity is there for a reason. It helps inhibit certain bacterial growth and fungal growth, and also acts like an insect repellent. When you've got otitis externa, when you've got an outer ear infection or inflammation like this patient has, the pH level from the ear canal changes from an acidic to an alkaline pH. So the acetic acid, it's almost like it's just a vinegar spray almost. It's designed to re-acidify the ear. And so recommended the patient to get this spray over the counter, but I have also written to their GP because there's a prescription antibiotic spray which also, not only does it contain acetic acid, but it also contains an antibiotic, neomycin, which is an aminoglycoside. So what an aminoglycoside does, it stops the bacteria from reproducing. It enters the cell of the bacteria, and there's a structure called an organelle, I should describe it as, called a ribosome. And the ribosome is important in the sense where it helps the cell to reproduce itself and replicate itself. So what the aminoglycoside does, it blocks the ribosome, and so it inhibits its ability to kind of genetically recode itself and multiply. And it also contains dexamethasone, which is a steroid and an anti-inflammatory, so it'll help with the inflammation. That should, I feel, do the trick. And the acetic acid as well, not only does it, as I said, not only is it antibacterial, but it can also help with a fungal infection as well. it may well be that the patient will have to have an ear swab taken by the GP or the ENT specialist to confirm the exact cause behind the otitis externa, because it has been chronic, it's been there for a while. So I recommended the acetic acid spray, written to the GP as well, requesting this other prescription spray for them. Advise the patient to avoid water. We do not want water, and they did go swimming recently and got water in, so I explained that water can exacerbate this, it can lead to swimmer's ear, so really asked them to be careful. Now the patient has also got glue ear. So glue ear is a build-up of sticky fluid behind the eardrum, and they had this as a child as well, and had grommets fitted as well to help them with that. Now I know some people may not like it, but there's a bit of skin at the top of the eardrum there. It was just not possible to remove. So, I think, well, I'm quite happy with what we've done. We've removed a lot, considering the patient has been kind of not been able to treat it by some other specialists because of the infection. I felt like I was really meticulous as much as I can, and we spent a long time today. We kind of ran over the appointment trying to get as much as cleaned as possible, and I tried my best to get this skin off at the top. It's not significant. It's not going to cause a problem, but it was just, the ear is so narrow. You can just view it and see how narrow it is as it gets, and there's just hardly any space, and it would just been uncomfortable for the patient. So glue ear, the patient had a history of glue ear, and they previously had grommets. So what is glue ear? Behind the eardrum, we have what we call the middle ear. The middle ear cavity starts from behind the eardrum and it goes towards the organ of hearing, the cochlea. So it's, in the middle ear, we've got 3 little bones, the ossicles. You may know them better as the hammer, anvil, and stirrup bones. Medically, the hammer bone is called the malleus, the anvil is called the incus, and the stirrup is called the stapes, and the stapes is the smallest bone in the body, and these 3 bones are connected. So the hammer bone attaches itself to the eardrum, and the stirrup bone attaches itself to the organ of hearing, and in between the stirrup and hammer bone you've got the anvil. So when the sound hits the eardrum vibrates. These vibrations are firstly transmitted through the hammer bone, then through the anvil bone, and then to the stirrup bone, which then stimulates the organ of hearing, the cochlea, and within the organ of hearing there's fluid and tens of thousands of sensory microscopic hair cells. And so when that stirrup bone vibrates, it goes backwards and forwards, it causes displacement of the fluid. So the fluid in the organ of hearing then travels in waves, and these waves, the length of the waves depend upon frequency of the sound. And these waves of fluid then causes these little sensory microscopic hair cells to shear to one side, depending upon the frequency. And when these hair cells shear to one side, they also contract, and they allow potassium to enter and calcium. This creates what we call an action potential. It creates an electrical signal, essentially. This signal is then transported through this sensory hair cell to the inner hair cell, because there's different types of hair cells in the organ of hearing, which then attaches itself to the auditory nerve, the hearing nerve, which then goes to the brain, to the auditory cortex, where we process it as sound. So, and that's a very simplistic, even though I feel that's very intricate and very complicated, just that, explaining it in that manner, but it is a lot more complicated than that, believe you me. So the middle ear, where the 3 bones is, and there's a tube in the middle ear called the eustachian tube, okay? Now, I'm going to come back to that in a minute. Now, the middle ear should be full of air, and it should be air-filled. And the air pressure behind the eardrum should be the same as the air pressure in the atmosphere. And that's when the air pressure either side of the eardrum, so the either side of the eardrum membrane, is equal, that's when the eardrum is most mobile, most compliant. And that's what we want, because that's going to optimise our hearing. And just when I hold that thought, it's going to just go back to the left ear. Now, this is the patient's left ear. This is actually their main ear. So when I performed the procedure, I actually started off with the left ear, and then I reverted to the right ear afterwards. But for the purpose of the videos, I swapped it around because the right ear was a bit quicker. If I may hold your interest a bit more. And this left ear, a lot of it's going to be tedious because I'm just going to be vacuuming a lot near the entrance as well. But you can see already all that greeny, yellowy discharge. I'm beginning to remove it. The skin I'm peeling towards the eardrum as well. It's going to look really healthy, this ear, once we've done. So as you watch, I'm just going to continue explaining about the middle ear. So just to recap, we want the air pressure behind the eardrum and in the atmosphere, so on the opposite side of the eardrum, in the atmosphere and the ear canal, to be equal. Now, what regulates the air pressure behind the eardrums? And that's this narrow tube, a narrow orifice called the eustachian tube. The eustachian tube connects the middle ear to the back of the nose, the nasopharynx. Now, the eustachian tube, the opening at the back of the nose is about 3 or 4 millimeters. The length of the eustachian tube is probably about 8 centimeters, approximately. Now, this eustachian tube is normally shut, and there's a reason for that. Now, if this eustachian tube is permanently open, it can cause upper respiratory tract infections to travel up the eustachian tube and in behind the eardrum, causing an ear infection, otitis media. So the reason why it's shut is a preventative measure. It's designed to stop bacteria or any sort of fungal infection going up the eustachian tube from the back of the nose and throat, entering the middle ear space. Also, the reason why the eustachian tube is normally shut is if it was permanently open, and some people have got that condition, it's called a patulous eustachian tube, then they can hear their own breathing, so their own breathing and maybe even heartbeat and pulse. It travels up the eustachian tube and it hits the underside of the eardrum, so it stimulates the eardrum from the underside as opposed to the outer side where the ear canal is. And that still causes the eardrum to vibrate, and then the bones to vibrate and the organ of hearing to respond. And also your own voice. So if the eustachian tube is permanently open, when you talk, not only is your voice, the sound waves, travelling into your ear canal, but it's also travelling up your nose. And it's hitting the underside of the eardrum, and you're also hearing it through the conventional way through your ear canal. So in essence, your eardrum is being stimulated twice by your voice, and it's going to be out of phase because it's probably going to travel quicker up your nose and hitting the eardrum from an underside than it is travelling to the ear canals. It's a shorter distance. So not only is your eardrum being stimulated twice by your own voice, but it's at different times as well, which causes your own voice to sound muffled. It's going to be a mismatch. So that's why the eustachian tube should normally be closed. And there's muscles at either side of the eustachian tube in the region of the back of the nose that actually contract. And when these contract, that's when the eustachian tube opens. So when do these muscles contract? So during brief moments of yawning or swallowing or chewing, the muscles either side of the eustachian tube contract. It causes the eustachian tube to open. And when the eustachian tube opens, it allows the air pressure to equalise. So if you've got excessive air pressure in the middle ear, so if the air pressure behind the eardrum is greater than the air pressure in the atmosphere, then air exits the eustachian tube. However, and most typically, if you've got less air pressure behind the eardrum compared to the atmosphere, when the eustachian tube opens, it allows air to enter. But in some people, the eustachian tube fails to open. It's blocked. Now, why is that? It could be anatomical. So they were just born with a narrow eustachian tube, and it's very difficult for it to open, even if the muscles do contract. It doesn't open enough. There could be inflammation at the back of the nose, mucus buildup, blocking the entrance of the eustachian tube. And other reasons could be that the muscles that contract are weakened. So it's just not allowing the eustachian tube to open. So they're the most common reasons why the eustachian tube doesn't open. Now, if the eustachian tube doesn't open, then all the air that is in the middle ear behind the eardrum, it gets sucked in, it gets evaporated, if you like, by the cells in the middle ear, because these cells need oxygen. So all the air that was in the middle ear gets absorbed by the cells that line the middle ear, which then creates a vacuum. There's no more air. And when you've got a vacuum and you've got no air in the middle ear, fluid is drawn out of these cells, okay? And this fluid typically would drain out of the eustachian tube. Eustachian tube is also a drain pipe, and also the cells that line the middle ear, it's the mucosa cells. So it's the same cells that similar cells that we have lining in the inside of our nose and mouth, the mucosa. So they are secretory cells. And so when they secrete a fluid, or when fluid is forced out from the cells because there's no air left in the middle ear because the eustachian tube is blocked, this fluid would normally drain down the eustachian tube because it's like a drain pipe. But if it's blocked, it can't. We call that middle ear effusion. Effusion is just a medical term for fluid buildup, or fluid. Now, this fluid will then build up further and further and further in the middle ear. It'll fill up the eustachian tube and then in the middle ear. And eventually this fluid will get infected. It'll become very thick and viscous, almost like glue, hence the name glue ear. But the medical term is acute otitis media. So otitis is infection of the ear, and media relates to the middle ear with effusion. Okay. Now, if you've got fluid behind the eardrum, it stops the eardrum from vibrating. It's just full of fluid as opposed to air. This fluid can start then eroding the bones, so it can get quite nasty if it's not treated. And the more and more fluid buildup you get, it can cause the eardrum to then bulge outwards, almost like a water balloon. Imagine if you've got a water balloon, you put excessive water in there. Eventually, it's going to have its breaking point and this balloon's going to pop. And similarly, if you've got too much fluid behind the eardrum, it has to go somewhere and it's going to rupture through the eardrum, causing a perforation and discharge. Now, glue ear can be quite common in children, and what's the reasons for that? Now, children growing up are going to be more prone to getting sniffles and colds and bugs and viruses, which causes upper respiratory tract infections, which will block the eustachian tube, preventing it from opening. So that's quite common in children. Also, in children, the eustachian tube is a lot narrower. So even if it is opening, it may not be opening enough, just because as the child ages, the eustachian tube should widen and get bigger. But also in children, the eustachian tube is more horizontal in plane, and as we get older, not only does the eustachian tube get wider, but it becomes more vertical. So gravity can help in adults to allow the fluid to drain, and children sometimes don't have that luxury. So it's quite common in children. Now, normally the guidelines in the UK is if your child has glue ear, it's a watch and wait strategy. Normally wait 6 months, and generally it clears, but in some children it doesn't. So what treatments and this is the treatments for children and adults are very similar. So even in adults, there is a watch and wait. The nice guy, we've got a set of NHS guidelines here, and that's what the guidelines suggest. Now, if the eustachian tube is blocked because of an infection and inflammation, so a bacterial infection, so you can give antibiotics. You can also give patients who suffer from rhinitis or sinusitis and problems in the nose, so deviated septum possibly, or enlarged turbinates, and any nasal congestion can cause a blockage of the eustachian tube. So sometimes you may need to have surgery in your nose, or adenoids removed, or just a nasal decongestion spray can help. And I had this beginning of this year. My left eustachian tube was blocked. I had a bit of a cold. It wasn't COVID, thankfully. We tested ourselves regularly. So it's just your common cold, really. And it blocked the left side of my nose. I had really heavy congestion, and it blocked my eustachian tube. And I developed a bit of glue ear. And if you visit my Facebook page or the Instagram page at the Hair Clinic, if you scroll through back to the beginning of the year, you'll see some images of my glue ear in my left side. So nasal decongestion sprays can help. Steaming therapies, so hot boiling water in a bowl, put some eucalyptus drops, menthol crystals, towel over your head and just inhale the steam. You can get menthol nasal sticks as well over the counter, so it's just a kind of almost like a muscle relaxant. It helps just open up your airwaves. That can also help. In the UK, we've got a device called the Otovent nasal balloon. It's a balloon that's designed to be inflated using your nose. So just say your left eustachian tube is blocked. You get this balloon, it comes with a nasal capsule. You attach the balloon on one end, The other end, you position it at the entrance of your left, if it's everything, your left side, your left nostril. You pinch your opposite nostril shut, you close your mouth, and you just blow into the balloon using your nostril. And as the balloon approaches the size of an orange, for example, I think they say grapefruit on the instructions, but I think people can more relate to an orange, a large orange, you swallow. And it just forces air up the eustachian tube, and that motion of swallowing again helps the eustachian tube to open so air can travel up to allow fluid to drain and air to pop the eardrum back out. There's another device called the ear popper, where it's a mechanical device. It's similar to the otovent nasal in some respects. You position it at the entrance of your nostril, you close the other nostril, you close your mouth, and you press a button and it mechanically injects air up your nose, and as it does, you swallow again. I think in America there's a device called the Eustachi. I think that's similar to the ear popper, if I'm correct. Now, if that doesn't work, and the watch and wait policy doesn't work, and all these things that I've just discussed doesn't work, and it's becoming an issue for the patient, there is surgery. So there's grommets, for example. So what is a grommet? A grommet is when a hole is, the eardrum is pierced using a scalpel, but done by an ENT surgeon. And if there's any fluid in the middle ear as well, they use a suction probe to suck out all this glue from the middle ear. And because air can't enter the middle ear via the eustachian tube at the back of the nose because it's blocked, a ventilation tube is placed through the eardrum so air can enter behind the eardrum via the ear canal. So it's a little grommet, a T-tube sometimes it's called, or a pressure tube, I think it's called, commonly known in America. Now, grommets can cause their own problems. Now, they do help to equalise the air pressure either side of the eardrum. Doesn't really typically affect the hearing. The hole is such a small hole in the grommet, so it doesn't have a massive impact on one's hearing ability. But you've got to be really, really careful when you've got a grommet because, you shouldn't be getting water in your ear anyway, because that can lead to otitis externa, swimmer's ear. But if you've got a grommet, the water can get through the grommet and enter the middle ear cavity, which can then cause otitis media, we just don't really want that. So you're going to be really, really careful with a grommet. And grommets can eventually fall out, so it may not be a long-term solution, although you can get a more permanent T-tubes which do last, it can be there for life, but it can last a lot longer than your standard grommet. So that's another option. And then there's another treatment that may work, which is called eustachian tube balloon dilation. It's a surgical procedure done under general anaesthetic. In essence, a balloon is inserted up your nose and up the eustachian tube, and it's inflated using saline solution for about 20 to 30 seconds. And this is designed to open up the eustachian tube. So it allows air to enter and fluid to drain. Now, that can, again, it can be beneficial for some patients, but not all patients, because sometimes the results are short-lived. Eventually, eustachian tube can get blocked, but sometimes it can lead to a patulous eustachian tube. So we don't want if it's overstretched, we don't want the eustachian tube to permanently open. So it's a difficult thing to treat the eustachian tube. I work very closely with a friend and colleague, Mr Darius Rajali. His YouTube channel, if you just type in Mr Rajali ear and balance, it might be. I have previously provided the link. I'll do it again in the description here. You can see some of the treatments that he performs, middle ear surgery for grommets and eustachian tubes. It's a very fascinating area. It's an area, I would say, of interest of mine, the eustachian tube. I've got a lot more to learn about it, but it is a topic that it does interest me. So we finished with the left ear. Again, there's a bit of skin left around the top, so I did try my best to remove that, and at the bottom, but it's just the ear is too narrow. Nonetheless, we've got the blockage clear. The patient could hear a million times better. So they're going to get the treatment for not only the otitis externa, the infection of the ear canal, but also their glue ear. They had glue ear on both sides. We confirmed that with the pressure test. The eardrum wasn't vibrating today. And we sent the letter in. Hopefully they'll be seen and treated by ENT shortly. I hope you enjoyed that video, guys. Take care and speak to you soon. Bye.